HLH is Hemophagocytic Lymphohistiocytosis. I'll call it HLH moving forward. And you get two types of HLH, primary and secondary. And what HLH is it's a hyperimmune, hyperinflammatory syndrome where a patient will present, very often a pediatric patient, will present with a number of signs and symptoms and laboratory abnormalities. And it's very severe, and in many cases these patients die from their disease. So they'll present with high fever, they'll present with a number of enlargements in different organs like the liver and the spleen. Their blood will be out of whack, they'll have very high levels of pro-inflammatory cytokines, they'll have low levels of platelets and white blood cells and red blood cells, which cause a number of problems. They'll have very high levels of ferritin, which indicates a hyperinflammatory state. And the objective here is to stabilize these patients. So typically they'll come in and they'll get corticosteroids, which is a strong anti-inflammatory, which will stabilize them. But primary HLH, the only curative treatment for primary HLH is hematopoietic stem cell transplant. So the objective here is to stabilize these patients when they come into hospital and then get them to a state of health where they can undergo bone marrow transplant. That's primary HLH. It's genetically driven, defect in the number of genes that predisposes them to this syndrome. There is secondary HLH as well. You can get secondary HLH due to infections, certain cancers, and autoimmune diseases such as Still's disease. So if I go back to primary HLH, the incidence in the US is about 80 patients per year, so it's a rare disease. But up until about 20 years ago, there really wasn't any treatment for HLH, and many patients died. And then there was the introduction of corticosteroids and the introduction of certain chemotherapeutic agents that have improved the treatment of HLH, but it's still not where it needs to be. It is difficult to diagnose because these patients will come in with a number of different signs and symptoms and laboratory abnormalities, and that could be due to many different diseases. Many different diseases do present like that, with high fevers and organomegaly and blood results that are out of whack. So it can be difficult, and very often the physician and the treating physicians at the institution needs to go through a number of different decision points to arrive at a diagnosis of primary HLH. A true diagnosis of primary HLH is done by genetic testing, but that can take up to 8 weeks to do. So when a patient presents, whether it's primary or secondary, it's not that important in terms of how they're treated when they come into the hospital. So emapalumab is a monoclonal antibody that is directed against interferon gamma. And interferon gamma is a pro-inflammatory cytokine that is central, one of the central inflammatory cytokines central to the disease of HLH. And what it does is it actually acts upstream. So what happens in HLH is interferon gamma stimulates macrophages, which in turn stimulates the release of pro-inflammatory cytokines like IL-1, IL-6, and TNF-alpha. So by acting upstream and neutralizing interferon gamma, it's going to improve the signs and symptoms and the laboratory parameters of these patients. Phase 3 trial has been concluded, and the data has been analyzed, and this data has been submitted to FDA, and we're hopeful to get an approved drug in November of this year.